internationally recognized Institute of Nephrology with publishing so many papers. I don't think he won't even know the number of papers he has published. So he's not only a great administrator, he is also a great researcher, a good teacher, a great teacher, and he's very clear in his thoughts and words, great orator, lover of Tamil literature. Even I am very eagerly waiting to hear him speak after a very long time. Over to Professor M.S.
அவைக்கு இந்த அன்பான வணக்கங்கள். உயர்வர உயர்நலம் உடையவன் எவனவன், மயர்வரும் மதிநலம் அருளினான் எவனவன், அயர்வரும் அமரர்கள் அதிபதி அவனவன், துயர் அரு சுடரடி தொழுதழன் மனனே. I profusely thank the founder of this great institution and the organizing team and my dear Vinoj for inviting me. It's a wonderful time I'm enjoying here in Erode in the midst of all of you. It's my pleasure and privilege. Also, it's a pleasure to be on the same stage with my old-time friend and contemporary Dr. Kannan. We did DM nephrology together. Arivalagan. I had the opportunity to train him, but now he can train anyone. And the respected other chairpersons, esteemed delegates, and my dear students. The topic for today's discussion is kidney and hypertension. Kidney, particularly chronic kidney disease with relevance to chronic kidney disease. It's a very vast topic. It's impossible to give a comprehensive account of this complex interrelationship and the strategies of management and the challenges ahead in a specified time of 30 minutes. So whatever has impressed me and whatever I felt is important to share, I'll just do that. So these are the four important the domains of my talk, like the bidirectional impact of hypertension and kidney, and a brief account of pathophysiology, and the management principles and the challenges ahead. Fine. So you all know the chronic kidney disease and hypertension, they exert a negative impact on each other. It's a bidirectional negative relationship. What do I mean by that? Can hypertension per se cause kidney injury? Yes, of course. Even though the existence of the pathological entity called benign nephrosclerosis is sometimes debated, let us not dwell into that. But it's pretty sure that any number of instances where do we come across in malignant hypertension, the kidney going in for rapidly progressive renal failure, biopsy revealing features, classical features suggestive of malignant nephrosclerosis. Also, the so-called thrombotic microangiopathy purely because of severe hypertension. So there is enough evidence to say that hypertension per se directly injures the kidney. That's number one. Number two, on the other hand, the hypertension's impact on the chronic kidney disease. The hypertension is an important determinant of the progression of chronic kidney disease. Whenever there is a chronic kidney disease, it is a natural history, varies from person to person. There are many determinants and many factors which reside on that. The hypertension is the single most important determinant of progression of chronic kidney disease. Not just that, Professor Chennappan just highlighted. Hypertension contributes for the cardiovascular morbidity and mortality in patients with CKD, and it also is a great independent contributor for all-cause mortality in patients with CKD. So it's a brief description. This itself can be elaborated. So you all might have come across this pathology, the classical malignant nephrosclerosis, the hyperplastic arteriolitis. Now there is tremendous proliferation of the smooth muscle cells of the arterioles in the kidney biopsy, the so-called onion skin appearance, and also there will be a kind of fibrinoid necrosis. Why it was called malignant nephrosclerosis and malignant hypertension, whenever you come across papilledema, because hypertension these days is that a person with this kind of a picture, their lifespan was equivalent to or less than that of an advanced cancer those days, because those years there were not many antihypertensives. It's only centrally acting drugs and hydrolazine, methyl dopa, clonidine, guanethidine, and so on. People of my age, we are at a vantage position to see the beautiful transformation of diagnostics and therapeutics, particularly in the field of hypertension. When I was a house surgeon, there was on one day in Madurai Medical College, there was a lot of festivity. Suddenly many people came in, and in our seminar hall there was a big gathering and meeting. What for? There was an introduction of atenolol. So that's what, actually, we used to prescribe only alpha-methyl dopa and clonidine and hydrolazine. Beyond that, there were no drugs those days. So that is why the survival was so less, so it was called malignant hypertension. Now it is not so. But still we want to retain that name, right? Fine. What is the role of kidney in causing hypertension? Is hypertension is due to the cardiac disease, actually because of the increased cardiac output and peripheral vascular resistance? What is the role? The kidney is only a victim all the time? No, it can by itself. The so-called primary hypertension, the so-called idiopathic hypertension, also most of the instances, the problem lies within the kidney. You name any cause of hypertension, you name any situation of hypertension, ultimately it boils down to reduced ability of the kidney to get rid of sodium. When more sodium is retained by the kidney, the result is hypertension. This is one important theory for the past 1.5 decades. It is making rounds. The so-called primary hypertension also is a renal hypertension. What is that? Any child born with a low birth weight, it's vulnerable, inherently vulnerable to develop hypertension and chronic kidney disease in later life. Why is it so? The low birth weight, the surrogate for a low kidney weight. A low kidney weight. A low kidney weight is a surrogate for low nephron number. Even though we all say there is 1 million nephron numbers of nephron in each kidney and all that, it's only just the kind of a median. It is a kind of a Gaussian distribution. On the one hand, there can be just 3 lakhs. On the other hand, there can be 15 lakh nephrons also. So those who are born with less number of nephrons, they are inherently vulnerable for hypertension. So kidney play a important role in causing the so-called primary hypertension. This is the mechanism due to genetic factors or intrauterine events and prematurity. That is why the prevention of chronic kidney disease, there is one more thing. It's not just primary, secondary and tertiary prevention. There is a primordial prevention. The prevention of hypertension, prevention of chronic kidney disease has to start with the betterment of maternity services. A pregnant woman's nutrition is very important. So if low nephron number happens, what happens? The remaining nephrons, the low surviving nephrons, they have to undergo work hypertrophy. They have to perform more work right from birth. That results in glomerular hypertension and intraglomerular hypertension, hypertrophy that leads on to glomerular sclerosis. Also retention of sodium. This is what is happening. Fine. So this is an important paper in Lancet. I happen to be one of the authors for this. Being a global burden of disease collaborator, I have contributed for this paper. This has analyzed the global, regional, national burden of chronic kidney disease over a period of 2-3 decades. So what does it show? So the updated figure, this is the CKD burden, global burden, 850 millions in 2022 across the globe. And the disturbing fact is that over a period of 2.5 decades, there has been about 30% increase in the incidence of chronic kidney disease. And most worrisome fact is that 1/3 of the global CKD burden is in India and China alone. And the chronic kidney disease contributes for mortality not just by advancing to end-stage kidney failure, but even prematurely it contributes for cardiac deaths. This is it. For the postgraduates here, this is an important, it can be your exam question as well. This is the topic of contemporary importance, the so-called CKM syndrome. You can't approach hypertension in isolation. You can't approach diabetes or obesity or kidney disease or cardiovascular disease in isolation. So there is a kind of a great interconnectedness of all these things. The C stands for cardiovascular disease and K stands for kidney, that is the chronic kidney disease, and M stands for metabolic syndrome, the CKM syndrome. We have been successful in starting an exclusive CKM clinic in Madras Medical College recently, where the patient afflicted with diabetes or hypertension, obesity, with a high risk for CKD, all the specialists will be there in the same clinic, analyzing and discussing interpersonal relationship, interdepartmental discussions, and the best outcome happens for the patient. So this is the stages of CKM. I will not go through that. As you can see here, the stage 0 is no risk factor. The stage 1, please remember, the problem starts with overweight. Anybody is overweight more than the optimal BMI is at a risk for CKM. That's what I would like to highlight. In stage 2 onwards, the kidney component CKD comes in. So any management of a patient with CKD and hypertension, diabetes and so on, you should have a kind of a broader vision of addressing the overall, the wholesome person who's at risk for cardiovascular disease and chronic kidney disease and so on. So with that in mind, the Department of Nephrology, Madras Medical College, with Community Medicine and Directorate of Public Health, we conducted the first of its kind statewide survey and prevalence of chronic kidney disease. What is the actual burden of chronic kidney disease in Tamil Nadu state? So first of its kind, and 4,800 adults representing the 6.5 crores of adults, they were selected by randomized cluster sampling technique, a step survey, and all the demographic data and urine protein was measured and looked with a dipstick and hemoglobin, blood sugar, serum creatinine. All the samples were transported to Chennai Central Public Health Laboratory with IDMS traceable serum creatinine. All data were digitally captured. The entire state was divided into 177 clusters, and the results were very, very shocking. The prevalence of hypertension among Tamil Nadu adults is 32.8%. Please believe what I say. Cutting across rural and urban Tamil Nadu. Diabetes 18.2%. The three categories, overweight plus pre-obesity and obesity, 60.5%. So this is the price which we pay for, quote unquote, the progress of the society. That's what I've been talking again and again. Altered lifestyle. Availability of per capita calories is more, consumption of calories is more, sedentary lifestyle, no physical exertion, and mental stress, and so on. So this is the alarming figures. And the most worrisome fact again is that among the diabetics, about 29.5% of them, and among the hypertensives, about 60% of them were not aware that they have the disease. First time it was detected. Fine. Why hypertension in CKD? CKD contributes for hypertension. Hypertension contributes for CKD, and CKD, almost 90% of our CKD population have hypertension. The exceptions are the chronic tubular interstitial pathologies where there is no sodium retention. There is natriuresis and diuresis, edema free. They can remain hypertension free. Otherwise, most of the chronic kidney disease causes, they have hypertension. That's it. Okay. So why there is acceleration or augmentation of hypertension in CKD is because of this. There is a progressive reduction in the sodium excretion, so sodium retention and volume overload on the one hand. On the other hand, there is endothelial dysfunction that leads on to increased peripheral vasoconstriction, and there is increased activity of the renin. The surviving nephrons, they are ischemic and they release more renin. There is activation of renin and there is increased sympathetic activity. So to simplify this, there is increased sympathetic activity, increased renin, angiotensin, aldosterone axis activation, and then endothelial dysfunction, and of course with progressive stages of CKD, there is sodium retention and volume retention. So you can broadly classify into volume dependent hypertension, volume independent hypertension. As the CKD stages worsen beyond stage 3B, 4 and 5, the volume retention, sodium retention becomes more important than the peripheral vascular resistance. So what is stage 4, 3 and all that? Is a very classical picture all of you might have come across. The CKD risk stratification. This is based on G1, G2, 3A, 3B, 4 and 5 and all based on the GFR, eGFR, estimated GFR. How do you do estimation of GFR? Using the CKD Epi app which you can download in the mobile itself. It's very, very simple. Less than a minute you can find out you can estimate the GFR, CKD Epi formula. On the right hand side, there is albuminuria estimation based on that A1, A2 and A3. So these combinations differently colored. Any box where there is red and orange and so on, they are at a very high risk for CKD progression. That's number one. Not just that, proportionately there is increase in the cardiovascular morbidity and mortality risk. So these patients have to be addressed very aggressively. And what is the BP goal in CKD by different guidelines? As Dr. Chennappan said, each guideline has got its own data. We all follow, nephrologists, we prefer to follow the KDGO, Kidney Disease Improvement of Global Outcomes. This is given a kind of a goal It is an utopian goal. It's very difficult to achieve a systolic BP. Ideally, you try to achieve less than 120 when the patient tolerates it. So that is it. And what is the method of BP measurement? It is not a simple office BP measurement. It is a standardized BP measurement, as it has been described by the first speaker, the professor of medicine. How many of us can afford to check BP with all those stipulations? It's impossible. Just 5 minutes, you have to just be looking at the patient silently without talking anything, and all other things is okay. Avoiding, no coffee in the previous 30 minutes, and leg not crossed, and arms resting, and relaxing, all that is fine. But 5 minutes, and BP checkup, and 2 times, and taking the average and all, it's very, very difficult. So if you, actually there are some studies, if you just casually, like as a routine office BP measurement, if it is around 135 or 130, that is equivalent to the standardized BP of 120. So, but this guideline says even the standardized BP technique, measurement technique, it has to be less than 120. That is almost impossible. So practically, we are happy if we are able to achieve a systolic BP of less than 130 and diastolic BP of 80. So that's it. Fine. So there are 2 important phenomena that have crept into the hypertension management recently. Number 1, the standardized office BP measurement is preferred. That's what they say. We have to keep that in mind. So we have to find out the proportionate equivalent in the routine office BP measurement. That is number 1. Number 2, there is a very high prevalence of white coat phenomenon as well as masked hypertension. So both are troublesome. So you have to prefer out of office BP measurement. There are 2 things. One is the ambulatory BP monitoring, the other one is the home BP monitoring, to supplement your standardized office BP measurement. So almost every patient of mine, I spend at least 5 times to them whenever I meet them for the first ever time, that you purchase one BP apparatus at home and learn how to measure it. And whenever you come for a follow-up, please come back to me with a profile of BP readings so that I'll be in a better position to prescribe antihypertensives. That's what I'm pleading and requesting. And it is percolating down into the society. Many people have started accepting it. And we need to have a low threshold to ask for ambulatory blood pressure monitoring. That gives you a lot of information, particularly the nocturnal dipping status, non-dippers and dippers, and the masked hypertension. That gives us a lot of information as to how to time the antihypertensives and so on. So these 2 things, please remember, these are the, whenever you refer any literature and even practically, these 2 things are very important. Fine. Then before going into pharmacotherapy as to how to manage hypertension, the lifestyle intervention, very often we neglect to spend time in kind of advocating on this to the patients. And just one advice doesn't percolate into the minds of our society. You have to be very emphatic in forcing this. What is this? A salt restriction. We are all we are salt craving society. That's how we have been habituated right from infancy. We have been attuned to high salt consumption. And unfortunately, our system has evolved in such a way to conserve more and more sodium, particularly the evolution of aldosterone. Without aldosterone, the life could not have migrated from the aquatic environment to land, because in the sea there is abundance of sodium. On the land there is no sodium. So until the aldosterone evolved, life could not migrate. That took millions of years. But that these salt retaining evolutionary mechanisms evolved as an advantage for survival when there was paucity of availability of salt. But now there is availability of plenty of salt, and that too with the current lifestyle and all the junk food and the ready-made foods, everything is salty. The chips and burgers and pizzas and everything is salt, and dangerous levels of salt consumption with intact salt conserving mechanisms within us. So that is the reason for the problem. Salt used to be a precious thing, in the medieval period. In fact, the salary, the English word salary, is derived from salt. Salt was more precious than gold. Wars were fought for salt itself. Why? Because there was no refrigeration. So the Western countries, Central Europe, there was no sea. Salt was not there at all. So they have to, and they were not able to grow either rice or wheat because of the inclement weather. So they were predominantly dependent on meat the meat will become rancid, so it has to be conserved with salt. If you add salt, it will not get spoiled. Why? Because the salt will increase the osmolality. The high osmolality environment will not allow the microbes to. That's why, the pickles does not get spoiled, because a lot of salt. So all that is old glory, but still we are retaining those practices and our salt conserving mechanism is intact. So the salt. Religiously you have to. And this practice has to start from early childhood. It's very difficult to get rid of salt consumption once you grow up. So ideally less than 5 gram of sodium chloride or 2 gram of sodium. So this is the prescription. Then physical activity. Again, we have to very vigorously be addressing this. And for a cumulative duration of at least 150 minutes per week. And smoking. Please ask this question. And the use of some drugs. That also is very rampant among the population now. And these are the lifestyle interventions before we think of any pharmacotherapy. Fine. And pharmacotherapy, antihypertensives, RAS inhibitors is the drug of choice for any kidney disease. Why is it so? RAS inhibitors meaning either AC inhibitor or ARB. Why? They are not just antihypertensives. Beyond that, they afford renoprotection. So this is the quick recapitulation of the basic physiology. This is the glomerulus, which is the functional unit of the kidney. That is a nephron. The glomerulus is the most important component of nephron. It's nothing but a bunch of capillaries. There is a beautiful arrangement of an afferent arteriole which breaks into cluster of capillaries. Normally from capillaries a venule only emerges, but here beautifully from capillaries again another arteriole emerges. There is afferent arteriole, efferent arteriole. There is a filtrate. Okay. What happens is that angiotensin II, it causes vasoconstriction of both afferent and efferent arterioles, but the vasoconstriction of the efferent arteriole by angiotensin is much more potent. So what will happen? Whenever there is angiotensin II excess, the pressure proximally builds that favors filtration. That's okay. But when there is heightened activity of angiotensin II, as I already said, increased renin release and angiotensin II activity, so there is excessive vasoconstriction of the efferent arteriole, there is increased intraglomerular pressure. The increased intraglomerular pressure, to start with, it is okay because the GFR increases, GFR is preserved, total GFR is preserved. But over a period of time, if the glomerulus is subjected to increased intraglomerular pressure, that goes in for glomerulosclerosis. So this is a hemodynamic effect. And then it has got multiple other mechanisms of renoprotection. Antiproteinuric. The more the quantum of proteinuria, please go, remember the initial slide which I presented. The more the proteinuria, more the chances for CKD progression as well as the cardiovascular mortality. And so the antiproteinuric effect of RAS inhibition is very important. And also angiotensin II plays an important role in, you name any mechanism of progression of CKD, it plays a role including promoting kidney fibrosis by elaborating TGF-beta. Also, A2 has to be handled very emphatically. That is why the RAS inhibitors are the first drug of choice. And any number of meta-analysis and studies, all that I have shown, the AC inhibitors as or ARB as a class, definitely to be preferred in preventing progression of CKD. But it's a very basic thing, but it's worthwhile to go back again to the basics. How to handle AC inhibitor ARB? Any drug is a friendly poison, particularly so RAS inhibitors. It is so renoprotective. We vouch for that, but at the same time it can play havoc. So this is the practice pattern. Whenever you start an AC inhibitor ARB, check the baseline serum potassium and creatinine. If it is more than 5.5, please don't start. Wait, repeat, and then only if the potassium is less than 5, start. Number one. Number two, after starting the drug, about a week or two, after about a week or two, please recheck serum creatinine and potassium. If the potassium goes beyond 5.5, again try to minimize the dose, reduce the dose, or withdraw and wait and then restart. And what will happen to serum creatinine after starting AC inhibitor ARB? It will increase. It is not a side effect, it is a pharmacological action. Please go back to, remember the previous slide. So A2 causes peripheral efferent arterial vasoconstriction. So increase in the intraglomerular pressure, so favors filtration. So when you knock off this mechanism, there will be a slight drop in the GFR, so serum creatinine will increase. But this increase should not be more than 30% from the baseline. So after checking the creatinine after 1 or 2 weeks after starting it, mandatory it has been checked. If the serum creatinine rises more than 30% from the baseline, just go through, anything else can be done. Any other drug which can cause a problem in GFR reduction, like a diuretic and other things. Or it is an opportunity to look for a hidden renal artery stenosis. Many times renal artery stenosis come to surface because of this phenomenon. And please remember, pregnancy is an absolute contraindication for ACE inhibitor ARB. And bilateral renal artery stenosis also is an absolute contraindication. Fine. So, this is an algorithmic approach. This is only a kind of a theory. Practically, any patient with CKD management, hypertension management in CKD, one thing is very clear, we have to start with ACE inhibitor ARB. Then subsequently how to proceed, you have to individualize. You have to individualize. Based on proteinuric or non-proteinuric CKDs, if a patient does not have no proteinuria, prefer a calcium channel blocker and then add thiazide diuretic, thiazide-like diuretic and so on. And keep on adding one after the other. And then mineralocorticoid receptor antagonist is an important addition now in resistant situations. Now there is a resurgence of interest in thiazide diuretics. Actually, diuretics, particularly thiazide diuretics, the classical teaching is that when the GFR falls to less than 30 mL per minute, it is not effective. But it is not so. The recent studies, this is a very important study, particularly postgraduate, remember this, CLIC trial published in NEJM. The chlorthalidone improves blood pressure in patients with chronic kidney disease and hypertension. Which stage? Stage 4, meaning GFR less than 30. So look at these favorable numbers in terms of reduction in the blood pressure and the proteinuria and so on. So there is a resurgence of interest in this. But hardly ever I prescribe thiazide diuretic, even though it is there in all the algorithms and all these things. We know thiazide diuretic is a very potent antihypertensive by causing natriuresis. But peculiarly enough, Asians, particularly Indians and particularly South Indians, we are at a high risk for development of hyponatremia. No harm in prescribing thiazide diuretic or thiazide like chlorthalidone. But don't prescribe if you don't have a facility or mechanism of periodically looking for electrolytes, particularly sodium. It is a very potent drug to cause severe hyponatremia. There are many deaths happen because of thiazide associated hyponatremia undetected. Because thiazide, hyponatremia is a big spectrum. On the one end, it will just manifest as fatigue. On the other end is the convulsions, coma and death. So you should have, whenever a patient is on thiazide diuretic, you should remember about this. These are the mechanisms. It causes sodium chloride, co-transporter inhibition. So excess sodium is let out. Not just that, enhanced expression of aquaporin in the inner medullary collecting duct. So water is reabsorbed. So the more plain water into the system, that causes hyponatremia. And also, these are the risk factors. Old age, women and low body mass and people who are on psychotropics and other drugs which can cause hyponatremia. Okay, so that's it. Please remember that. Fine, this is the consensus statement by Indian expert panel of Indian nephrologists. I had written a commentary on that. The same thing, RAS inhibitor is the first drug of choice and then individualize. We are not in a position to sermonize any physician to this is how you have to go ahead. That is the beauty of chronic kidney disease. Okay, and after all had trial, there was a lot of negativity and criticism on alpha blockers. So we were very perturbed because most of our patients on CKD, advanced CKD and that too dialysis patients, we used to add alpha blocker as a third drug or a fourth drug. That used to be very, very effective. And hardly ever we do come across with the modern preparations postural hypotension. So that prompted us to write a review article on this in JAPI many years ago. So there is an argument for favoring alpha blockers in kidney disease. As I've already said, there is heightened and enhanced sympathetic activity. So certainly alpha blocker and beta blocker, they do have a role, but we need to, not as a first line or second line, at least as a third line. Okay, that's it. And resistant hypertension, whenever you come across resistant hypertension, please, first and foremost thing is that think of non-adherence. People will not reveal it out. This non-adherence is a major problem haunting us, including doctors, including the so-called quote-unquote well-educated people. In fact, many of our well-functioning kidney grafts after transplant, they are lost because of non-adherence to immunosuppressive medication. So keep on asking this question before adding another drug. Non-adherence is a major issue. Okay, then stepwise approach, keep on adding one after the other drug based on the comorbidities profile and age and other demographic data and so on, the tolerance of drugs and so on. And please remember, another important problem nowadays that's happening is obstructive sleep apnea. This is another entity which is increasingly prevalent but under-recognized, grossly under-recognized. Please always have an index of suspicion in any person who complains of fatigue, obesity, daytime sleepiness. You have to ask for this history. And snoring. Have a very low threshold to go for sleep study. Very high prevalence. So this is the, more than 1/3 of the CKD patients have comorbid obstructive sleep apnea. This is a global prevalence. Okay, and I've already said about 60% of the Tamil Nadu adults are overweight and so on. Very highly prevalent. If you don't address this obstructive sleep apnea, your treatment is incomplete. You are doing rather harm to the patient. So please get sensitized on OSA. Have a low threshold on sleep study. And there are any number of instances where with use of CPAP, their entire lifestyle changes, the patient becomes totally positive. And weight reduction becomes possible, and going in for physical activity becomes possible, and there is a reduction in the blood pressure as well. It's an important cause for resistant hypertension. So this is what is happening. In obstructive sleep apnea, there is fragmentation of sleep, and there is hypoxemia, and that causes a stress on the entire system. There is endothelial dysfunction and hypertension, and worsening of the chronic kidney disease and so on. And hemodialysis, and then next, let me move on to the CKD stage 5 and hypertension in hemodialysis and peritoneal dialysis. Controlling blood pressure in a patient on maintenance dialysis is a tough task. I think all the nephrologists here will accept. And again, there is no fixed number to say that is the target for BP that is to be achieved in a patient on hemodialysis. That is number one. Number two, if you are very drastically bringing down the BP, the fistula will close. Intradialytic hypotension and fistula closure, fistula failure is another big problem. So, again, the ambulatory blood pressure monitoring gives us a lot of information, and don't just rely on the pre-dialysis BP alone to take a call. And there is some role for contributing for hypertension by the important drug which all the patients on dialysis they get, that is erythropoietin. It increases platelet aggregability, vasoconstriction and so on. But that does not preclude the use of erythropoietin. And Dr. Chennappan pointed out there are three important newer classes of drugs, SGLT inhibitors and GLP-1 receptor agonists and non-steroidal aldosterone receptor antagonists. These are all renoprotective and cardioprotective, and they all help in subtly reducing the blood pressure as well. But about this non-steroidal aldosterone antagonist, receptor antagonist, I have got my own reservations because most of the Indians cannot afford for it. But I'm a great prescriber of aldactone, spironolactone for many years. The same thing, aldosterone antagonism. Only thing it is non-selective. The male gynecomastia has a problem, but otherwise it's a wonderful drug. Those who have been on this 12.5 milligram for many years, I have been following them as CKD patients without great progression over 15 years and so on, and very inexpensive as well. And for those nephrologists here, they all come across this another problem. 15% of the patients on dialysis, they develop severe hypertension after initiation of hemodialysis. It's a very big problem. And volume overload, increased sympathetic activity, and these are the pathophysiological mechanisms. Because some of the antihypertensives are removed during dialysis, so prefer antihypertensives which are not removed during dialysis in these patients, like beta blockers and RAS inhibitors like losartan and valsartan, and calcium channel blockers like amlodipine. But the most important thing in these patients is that absence of edema is not equivalent to absence of volume overload. Without edema itself, there can be volume overload. That is the beauty of CKD hemodynamic mechanism. So you have to keep on reducing the dry weight. And lastly, a couple of slides on post-transplant hypertension. Again, after successful transplant as well, the hypertension prevalence is very high, from 24 to 90% in different studies, because it by itself can have a negative impact on the graft as well as contribute for cardiovascular morbidity and mortality. And these are the causes. Apart from the routine causes, excessive weight gain after successful engraftment. We do have patients who have gained 20 kilos of weight in 1 year, first 1 year post-transplant. Vengeful eating after successful engraftment, and then steroids and calcineurin inhibitors, cyclosporin and tacrolimus, they also contribute for hypertension. And this is our own publication on post-transplant hypertension. The prevalence was about 83%. And as you can see here, the mean weight gain over 1 year was 12 kilos in our 37 patient study. And the risk factors for post-transplant hypertension were use of cyclosporin, metabolic syndrome, and male gender. So let me conclude with these important the take-home messages. One, hypertension is a huge medical problem. It's a global problem, and it has got a formidable negative impact on the kidney. And lifestyle intervention is as important or even more important than pharmacological intervention. And prefer RAS inhibitors as first line of therapy in any form of chronic kidney disease. And individualized management strategy, that's very important. And beware of RAS inhibitor-induced hyperkalemia and thiazide-related hyponatremia is very important. And obstructive sleep apnea is unrecognized. Please recognize and address that. And non-adherence to medications is highly prevalent. It is a very important thing we addressed. And whenever you come across a resistant hypertension, think of renal artery stenosis and monogenic hypertension. Whenever there is a hypertension and hypokalemia or even low normal potassium, please think it can be a monogenic hypertension. Give aldactone. Even then, the BP is not getting controlled. Give amiloride without going in for even renin activity and all that. If ideally it has to be done, but any number of instances that we have done. And there is a huge importance and role for ambulatory blood pressure monitoring and home-based blood pressure monitoring. These are the paradigm changes in the hypertension management. Thank you so much. Sorry, I have exceeded by 2 minutes.
Very informative talk from your side, sir. So many general physicians here. So when a patients with uncontrolled hypertension, young patients or any old patients, means what are the red flag signs for the referral to specialist, especially nephrologist for a renal biopsy, sir? Can you enlighten on it?
Right. So first thing is that whenever you come across a patient with hypertension, the most important thing is the head-to-foot examination. At least once, head-to-foot examination, measurement of BMI, and palpating all the peripheral vessels, checking BP in all the 4 limbs. So these things itself will, to a large extent, will rule out the aortoarteritis and other things, the vascular causes for hypertension and so on. And at least once you have to look into the fundus to know the hypertensive retinopathy is there or not, and get an ECG done to assess whether there is LVH or not. So the target organ damage. Then a detailed history, that's very important. Most of the young people, particularly the IT sector people and all that, they continuously do night duty because they are linked with some US based company and so on. So they change in the lifestyle, and if there is central adiposity and overweight, a reduction in the weight, all that has to be done. Then you start on drugs. And then basic investigation, mandatory investigation is at the first visit itself, you have to look for presence of kidney disease, either as a cause for hypertension or as a consequence of hypertension. Very simple thing, serum creatinine, and apply CKD epi formula and then estimate GFR, number 1. Number 2, do a urine analysis. Look for presence of proteinuria and do urine sediment to look for presence of RBCs. If there is plenty of RBCs, repeat. If there is a persistent hematuria, please immediately refer because it can be primarily a glomerular disease or something else, number 1. And there is a significant proteinuria, more than 2+ dipstick proteinuria, please refer to a nephrologist. And then, if you are not able to control BP, even after lifestyle intervention and with 2 drugs, better think little widely as to what's happening and then refer to a specialist. And then, of course, lipid profile, associate other investigations, minimum investigations is at least once electrolytes. Because if there is hypokalemia, if you pick up a hypokalemia and hypertension, the management is entirely different. It can be a monogenic hypertension. Then, lipid profile, you have to address with the statins aggressively for that. And then ultrasound to look for the kidneys.
Thank you, sir.
If there are no questions from the audience.
No, madam is asking something. Yeah.
Thank you.
Yes, madam. Microalbuminuria.
Albuminuria means microalbuminuria?
No, madam. I said dipstick. Dipstick, macroproteinuria. It's not mandatory that you have to go look for microalbuminuria in hypertension. No, madam.
Sir, all premature babies will have low nephrons?
More likely. It's at a high risk. So we have the management starts from the better maternity care.
So the size of the kidney means that smaller kidney means low
in all
nephron.
probability, the number of nephrons may be less. So we say hypertension is a fetal flaw.
Thank you.
Thank you,
As
sir,
usual.
for so beautifully elaborating on the renal aspects of hypertension. As a doyen in the field of nephrology with decades of invaluable experience, you have truly enriched our understanding and helped the delegates grasp the practical nuances with great clarity, sir. Thank you very much. May I now request our chairpersons to hand over the memento to our speaker. I request Dr. Harinivas, sir, to kindly hand over the mementos to our esteemed chairpersons. Dr. Kannan, sir, nephrologist, Erode.